clinical hematology, and these are the two candidates who have joined us. And this is our bone marrow transplant team. This is the real backbone of any transplant activities that we do, and it's a matter of life and death for the patient how these people react and respond on a day-to-day basis. Now, this is a snapshot of the OPD patients, new OPD patients that we see, and you can see that the graph has been growing exponentially. This year up to September we had 481 new OPD patients, and we are projecting that by the end of the year it will be 640. The type of patients that we have can be divided between benign disorders and hematological malignancies, and this is a snapshot of the most common diagnosis that we have in our patients. The common references that we get are for refractory anemias, thrombocytopenia, coagulation disorders, thrombosis, ICU consultations, and surgical clearance. And on an average it is about 12 to 15 such consults that we get every day. As far as bone marrow transplant is concerned, we started 4 years ago, and you can see that from 1 to 3 to 11 to 25 patients we have done. This year it is up to September 25 patients, and we have moved from autologous transplant in blue to allogenic transplant in orange, and the grey bar that represents a haplo-identical transplant that we have started this year. With this brief introduction, now I invite Dr. Abhilash Reddy, Senior Resident, to present the case. Over to you.
Good morning all. I am Senior Resident in Medical Oncology Department. Today I am going to present the case of a 14-year-old boy who presented with fever and rash. So this is a 14-year-old boy who is a student of class 9. He presented with a fever of 7 days, generalized weakness since 7 days, and red spots all over the body. Red spots over the body since 2 days. So his fever was intermittent, high grade, not associated with chills. There were about 2 to 3 spikes per day, which was the fever was subsiding with medication. Red spots were seen on the arms, legs, back. No itching was seen. The spots were progressively increasing in surface area. There were no aggravating or relieving factors. It was not, the fever and rash were not associated with cough, throat pain, chest pain, breathing difficulties, ruling out any chest pathology or pneumonia. Not associated with pain, abdomen, loose stools, vomitings, ruling out gastrointestinal symptoms, or also not associated with joint swelling, joint pain, stiffness, etc. Ruling out collagen vascular disorders and other rheumatological disorders. There was no signs of UTI, no signs of any bleeding diathesis. There was no sign of any meningitis. No signs of yellowish discoloration of urine or abdominal distension, ruling out any liver-related disorders, and there was no history of any consumption of drugs in the recent past. He also doesn't have any significant past history. He is a vegetarian by diet. He has adequate calorie and protein intake. His appetite is normal. Bowel and bladder are normal, and he has adequate sleep, and he doesn't have any history of surgeries. His birth and developmental history was normal. He was completely immunized. He belongs to upper middle class by socioeconomic status. His family history: his father has asthma, and he's on medication. There is no other history of any infections or malignancy in the family, and there is no previous history of hospitalization for this patient. So to summarize, this is a 14-year-old boy with a short history of fever and rash, completely immunized, and no significant past history. Now at this point I would like to ask the audience what could be the possible differentials based on the history available. Differential diagnosis in this case possible are infections like bacterial, viral, or any other infections like malaria or rickettsial infections, drug-induced fever and rash, and then there could be malignancies like acute leukemia, and it could be due to any other autoimmune disorder. Now we did a general physical examination for the patient. It was a history of patient was having fever of 101 degree Fahrenheit. he was having tachycardia. There on skin examination, it was multiple red non-blanching macular lesions of various sizes ranging from 1 mm to 1 to 2 cm or present on arms, legs and back, suggestive of petechial. There was no sternal tenderness and there was no lymphadenopathy seen. There were no wet purpura either. On systemic examination.
Let's say ये petechial और purpura और acomyces में क्या difference होता है?
Sir, petechial or small red color dots which are about 1 to 2 mm in size, sir, less than 3 mm. Purpura are little bit bigger. They might be up to 3 to 1 centimeter in size, but ecchymosis is quite larger lesion. Which
except the size, there is no difference.
Yes.
All right.
Yes. Yes, so there are petechial and some purpura and petechials.
1 to 2 centimeter will purpura.
Yes.
palpable है
non-palpable?
palpable को क्या बोलेंगे? Macropapular नाम सुना है?
Yes, sir. Maculopap.
What is the name of that?
So,
purpura जो palpable हैं? No. The macro. What is the name of the palpable purpura?
Online purpura is one. Normally with abdominal pain and thrombocytopenia on camera.
Systemic examination was sized to. Yes, sir. Okay, sir. Systemic examination was suggestive of tachycardia, and patient doesn't have hepatosplenomegaly. Otherwise, the rest of the examination is totally unremarkable. So, at this point, I would like to ask the audience, which is the single most important investigation here that would help in diagnosing the case further.
So anybody from the pathology department, from pediatrics, medicine, which is the single most important investigation? That should not be a difficult one. Go ahead. I can see you.
CBC.
CBC associated with a PBF.
And also, what other investigations would you like to order for this patient along with CBC? So here in this patient we did a CBC which was suggestive of anemia. The total leukocyte count was more than 1 lakh with so it was suggestive of hyperleukocytosis, and the patient is having severe thrombocytopenia, and on peripheral blood smear it was suggestive of 85% blasts. LFTs were normal. Renal function test was showing increased uric acid with 8.5. LDH and coagulation profile were normal. So how would you like to evaluate this case further?
तो क्या diagnosis हुआ इसका? बोलो जल्दी बोलो. We have to move on. Long presentation, 100 slides. Acute leukemia, right? Agreed? There cannot be anything else. Do you want to do some more tests? Do you want to start treatment now? What test? Yeah, of course. You want to know what type of acute leukemia it is, because prognosis is different and treatment is different.
So we did a bone marrow aspiration and biopsy. It was suggestive of acute leukemia with almost 90% blasts. A flow cytometry was done, which was suggestive of acute myeloid leukemia with monocytic differentiation. These are the positive markers on the flow cytometry. And are we ready to start the treatment yet, or do we need any more information? So now after the diagnosis is made.
So in today's time, in an advanced center, hematology center or oncology center, just knowing that the patient has AML is not enough. You have to risk stratify that patient. You have to find out whether that patient is in good risk, intermediate risk, poor risk. Again, this is important from your treatment point of view. And the second important thing before you move on to treatment is you want to find out if there are any targetable mutations present in your case, because we have a whole bunch of targeted therapies which are now available. You want to make sure that you're not dealing with AML M3 or acute promyelocytic leukemia, in which the treatment is completely different and the prognosis is excellent. You cure 9 out of 10 patients. So just knowing AML, ALL is not enough now. We have to do some more risk stratification.
So we went on and did karyotyping, but there were no adequate metaphases available for the result, so that the result was failed. Then we did a molecular panel which was suggestive of BCR-ABL, ASXL1 mutation was positive and KRAS mutation was positive. Now on the screen we can see revised European Leukemia Net Classification System, which categorizes the AML into favorable, intermediate and adverse risk. In our patient we have these two mutations positive, BCR-ABL and ASXL1, which puts the patient in an adverse risk group. So the final diagnosis is acute myeloid leukemia with hyperleukocytosis with adverse risk category. So the management plan of this patient is to give supportive care along with chemotherapy.
So all of you will remember the FAB classification, French, American, British classification, M1, M2, M3, M4, M5, M6, बाद में M0 भी add हो गया था, M7 भी add हो गया था. That is just a morphological classification. So that is not important for us anymore. Only the M3 part is important. So we've moved on to molecular or genetic gene level classification now for most of our patients.
So for management we will we give supportive therapy also, which is important as treating the disease with the chemotherapy. For supportive therapy in this patient we gave allopurinol to decrease the raised uric acid because of high WBC count, so as to prevent his renal failure, and we gave him capsule hydroxyurea. This is to decrease the total cell load, and then we give bacterial and fungal prophylaxis with lofloxacin and fluconazole, and we had also to give multiple transfusions with platelets and RBCs were given. Whenever required, electrolyte correction was also done. In this particular patient, we have to always remember about the high risk of tumor lysis syndrome, which is associated with high total leukocyte count. So adequate hydration should be maintained, and we should continuously monitor his CBC, RFT, serum potassium, calcium, phosphorus and uric acid levels. So this is the basic treatment algorithm for AML patient. We divide the patient into favorable risk, intermediate and adverse risk. Our patient falls in the adverse risk, so we start with induction therapy with daunorubicin cytarabine based therapy, and then we take him for allogenic stem cell transplant once he achieves complete remission. Treating an acute myeloid leukemia patient.
Dr. what is the position of a stem cell transplant in our place?
So we have that in this presentation itself, sir. We'll update everybody as to how many we've done, and in this
Anil Suri is there today?
जी सर?
Anil Suri.
नहीं, अनिल अभी यहाँ पे तो नहीं है सर.
Treating AML is a labor and resource intensive process. We keep the patient admitted for almost 3 to 4 weeks because so we might always need a patient to have central venous access is required, and there might be multiple transfusions needed during the process with RBCs and platelets, and these patients are mostly severely immunocompromised, and they have a very high risk of life-threatening bacterial and fungal infections. So in this patient, the induction chemotherapy was given with the daunorubicin and cytarabine. It is known as 3+7 regime because we give 3 days of daunorubicin and 7 days of cytarabine. Along with that, dasatinib was given. Dasatinib is a targeted therapy for BCR-ABL positive mutation. So as our patient has the mutation, we also gave dasatinib. And after the completion of the chemotherapy, a response assessment was done with bone marrow aspiration, which was suggestive of morphological remission, but still there was measurable residual disease of 1.94%. So we had to go for giving a second induction chemotherapy, and high dose cytarabine with dasatinib is given. And after that, after this chemotherapy, again we repeated bone marrow. It was still in morphological remission, but still the patient had persistent measurable residual disease of 2%. We went ahead with giving a second line treatment with one cycle of decitabine and venetoclax. Then we repeated the measurable residual disease, and it was undetectable at this point. So after this, we planned for an allogenic stem cell transplant for this patient.
Tell us what are those drugs that you named just now and what do they do exactly that you got undetectable?
Sir, decitabine is a hypomethylating agent, sir. It is a chemotherapy drug, and with that venetoclax is a BCL2 inhibitor. It helps in targeting the AML cells. Sir, now I would like to call Dr. Naveen Gupta, sir, to further discuss about allogenic stem cell transplant.
Thank you, Dr. Abhilash. Very good morning. So we have a case of high adverse risk acute myeloid leukemia, and with much difficulty we have been able to achieve complete remission in this case. Now this remission is not going to be long lasting in this case, and there is a very high risk of relapse unless we go for an allogenic stem cell transplant. So the further course of the patient I will be discussing here. But to begin with, there is some confusion over the terminology. The commonly used terminology is a BMT or a bone marrow transplantation. But now the spectrum of transplants has become wider, and bone marrow is not the only source that we use for the stem cells. They can be even collected from the peripheral blood. So the more accepted terminology is a hematopoietic stem cell transplant, or maybe just a hematopoietic cell transplant. There are two major types, autologous and allogenic. In our case, in a leukemia, you require an allogenic transplant. You need to clean off the marrow and replace it with another healthy marrow. So the first thing that you need in an allogenic transplant is a donor. So how to identify a potential donor for an allogenic transplant? Here lies the important role of HLA typing. HLA stands for the human leukocyte antigen, located on the short arm of the 6th chromosome, and it codes for the proteins in the major histocompatibility complex. And this is basically the signature that every cell carries, every nucleated cell carries. And our immune system can use these to differentiate between self and non-self. There are two classes of HLA genes, class 1 including HLA A, B and C, and class 2 including HLA DR, DQ and DP. And all of these genes have two alleles, one haplotype inherited from the mother and one from the father. So we've got a total of 12 genes that we need to look for. And as I explained, are the cell surface markers, and they can be used by our immune system to recognize between self and non-self. And the inheritance of the HLA genes follows a haplotype pattern. There is very minimal crossing over in meiosis, and a complete haplotype is inherited from a parent. So we have a possibility that the same haplotype coming from both the parents can be there in siblings, and if that is the case, then both the siblings will have a complete HLA match. In our patient, the patient had a younger brother with whom he only had a 6/12 match. Only one haplotype was common, and the same status was there with the father and the mother. So basically, we had a patient where we did not have a full match. So what to do when we don't have a full match for an allogenic transplant? The first thing that we always do is search for siblings, but if we don't have it, then the next option is to search for a complete HLA match through donor registries. And these are large registries which contain HLA data of lakhs or maybe even millions of people, normal population who are voluntarily giving their data and voluntarily submitting that they may be willing for a donation of a stem cell transplant later on. We did a merge search in this patient through the Indian registries, and we were not able to find an HLA unrelated donor also. So the last option that we were left with was an haploidentical transplant, in which we proceed with a transplant with only a 50% match. That obviously has much more complications. The rejection rates are high, the complication rates are high, but in this patient, this was the only option that we had. This is actually a report of the patient showing a haploidentical match. Now, to select the donor, we had all three donors having a haploidentical match. The brother was quite young, and the family was not willing for him to be a donor, otherwise he could have been a donor. For multiparous women, we usually do not prefer to take from them. So we were left with the father, the patient's father, who was having a 10/12 match. So then, as with the father as a donor, we proceeded for a transplant. The overview of the transplant scheme is this. So we've got chemotherapy, conditioning chemotherapy, which would ablate the marrow of the patient. We would then do a transplant from the stem cells which we have collected from the donor. This recovery of hematopoiesis will take 2 to 3 weeks from the infusion, And during this period, the patient's blood counts fall to complete zero, requires multiple blood and platelet transfusions. There is an extremely high risk of infection. So all of this process is carried out in strict isolation inside the BMT unit. The patient has to remain admitted for a duration of around 30 to 35 days. Subsequently, once the donor hematopoiesis is established in the patient, immunosuppression is required so that the donor T cells do not start damaging the host tissues. This is a condition which is known as graft versus host disease. So it's a busy slide, but please bear with me with this part which I have highlighted in the red. This is the conditioning regimen that we gave our patient, containing of 3 drugs, busulfan, fludarabine and cyclophosphamide. The days that we have numbered here start from -7 and they go all the way to positive. So the day 0 is basically the day on which we do a transplant. All days before that are counted in minus, all days beyond that are counted in plus. So this was from day -6 to day -2 a conditioning regimen. Alongside this conditioning regimen, we have to start preparing the donor also for collection, and immediately prior to day 0 we will do a collection and infuse the stem cells. So stem cell collection from a donor can be done in 2 ways. As I mentioned, bone marrow is the traditional one, and what is now more preferred in the newer era is a peripheral blood stem cell collection, and it becomes a completely non-surgical mode of collection. What we have to do is we have to mobilize the stem cells from the marrow and get them into the blood and then collect them from the blood. Makes it a completely non-surgical process, easily well tolerated, and has various advantages, particularly in cases of leukemias. So how do we mobilize it? We give granulocyte colony stimulating factor GCSF, the injections that we have commonly used to increase the WBC counts in neutropenic patients. And that is given at a dose of 5 microgram per kg subcutaneous for twice a day for 5 days. So this process is going on simultaneously while the conditioning is going on, the mobilization process, the yellow bar at the bottom. And after 5 days of GCSF, we have to collect stem cell by means of apheresis. To discuss the part of apheresis, I would like to invite Dr. R.M. Jaiswal sir, professor in immunohematology.
Very good morning, Emeritus Chairperson sir, VC sir and former VC sir and pro VC sir. And I'm going to take to the how we are collecting peripheral blood stem cell in our blood center, because this is just when we plan for the stem cell collection, so we are having the close association with our hematology team, and they inform us to ready your machine after 5 days because we are going to collect on the day 5th. And how we are going to collect, because when we are going to collect, the first we need a mobilization of the stem cells, because in a normal basal rate, the normal stem cells present in the body, but that is less than 1%, hardly 0.1% population is present in the normal body. We need to mobilize them to throw into the peripheral blood so that we can collect adequate number of CD34 positive cells. CD34 positive cell is the expression of hematopoietic stem cells by which we are identifying if we are dealing with the hematopoietic stem cells. So CD34 is one of the most important predictive marker to decide the collection of apheresis of the peripheral blood stem cell product. Then in this process, first we need to administration of the mobilizing agent, either GCSF, then pre-harvest CD34 evaluation. On the day before of the harvesting process, we need to ask for the CD34 evaluation, and we need to check how much CD34 present in the body before the collection. Because CD34 collection enumeration decide how much volume we are going to collect from the apheresis machine, and ultimately this decide the dose of the product. And then assessment of adequacy, it is also very important. After the collection of product, PBSC in the product, we also need to check how many CD34 positive cells we are collected in our PBSC product. This is our machine, that is the compact machine. This is the multitasking machine. By this we are doing therapeutic plasma exchange, granulocyte collection and peripheral blood stem cell collection. But the programming is different. For different collection thing, we need to be set the different program, and we need to set when we are doing the PBSC collection, we need to set, we are having the specialized dedicated kit for the collection of peripheral blood stem cells. We need to be record donor and patient parameter, just like because now PBSC collection comes under the DGHS and licensing part.
So we need to fulfill all the criteria as a normal donor. Even we are dealing with the autologous. So we need to take care of these all the information as a donor, even if the patient is a recipient, because sometimes in autologous patient, recipient and donor both are the same. Then vascular access is the very important part, because as Naveen mentioned, this is a non-surgical procedure. We don't need to do any kind of surgery in this type of transplant, because most of the time when we thought about the transplant, so surgery always comes in our mind. So in this process, we need to connect peripheral blood stem cells from the peripheral vein if the venous access is good. If the venous access is not good, then we need to choose the central line. Then this is Sir, normally we are preferring peripheral blood, this anticubital vein, if the vein is good, because we don't need to put any central line. But sometimes, because if we are dealing with the autologous, the patient veins are already compromised because of multiple chemotherapeutic agents. In that case, we need to choose central line. Central line is preferred over femoral line, and sometimes if central lines we are not getting, then we go for the femoral. So we are having all the three options, and the priority: peripheral vein, then central line, then femoral. So you want. Then we have to check the vascular access, because this is the continuous flow machine. In this machine, we need to put two cannula, one in this arm and another in the second arm. So in this procedure, we need to collect whole blood, and by the centrifugation process, the mononuclear cells, which is containing CD34 positive cells, they are separated in the separated bag. And during the collection of the procedure, we closely monitor the adequacy of our product by seeing the color of the bag. And then we have to check CD34 cells in our product, because it is normally considered if the product is having more than 2 into 10 to power 6 kg body weight, that is a sufficient dose. And if we are collecting more than 5 into 10 to power 6 per kg, then the engraftment is very fast, and it gives tile image hematopoiesis achieved earlier. So we have to be very careful when we are doing collection by checking the continuous, the machine and product color to achieve our desired dose. And this is our CD34 report. I think it is visible. You can see CD34 is the pre-count before the collection, that is the 147, and after the collection, the product CD34 shows 2380. It means we achieved our desired dose, very well desired dose in the product. And this is the calculation of the stem cell, and sometimes it needs to be modified according to the patient body weight and requirement. And now I am inviting to Dr. Abhilash for the further.
Thank you, sir. Here we see a picture of recipient stem cells being infused into the donor via syringe through the central vein. Here the total CD34 stem cells are 2.3 into 10 power 6 cells, and the stem cell dose that we gave to this patient was 7 into 10 power 6 cells per kg body weight. Here in this bag we can see the stem cells that were collected from the donor. Again, this picture we can see on day 0 stem cells were given. After that, I'm going to discuss what we did post-transplant. Post-transplant, we gave him cyclophosphamide, cyclosporine, mycophenolate, mofetil. These drugs are essentially given to bring the patient to some immunosuppress the patient, so that we can prevent graft failure, and also we can prevent GVHD. Here we see a graph. This is about the cell counts, the trends of the cell count pre and post hematopoietic stem cell transplant. In this graph, on the x-axis we see days from the transplant. On the y-axis, on one side we see absolute neutrophil count, which was in red, and on the other side, there are platelets which are represented in blue. So initially, when we took the patient for transplantation, his counts were normal. It is around minus day 6, and after that we gave him the conditioning regime. And on day 0, we gave him the stem cell transplantation. With the conditioning regime, all the cell lines have slowly started coming down. By day 4, they were almost zero. And this is known as a nadir phase. From here, for the next 8 to 10 days, he was having zero neutrophils. After that, once the stem cells start replicating, the number of neutrophils start to grow, and by day 14, his neutrophils have come above 500. At this point, we call it neutrophil engraftment. It is first of the 3 days when the stem cells were continuously, the neutrophils were continuously more than 500, and by day 17, platelets have also engrafted. So after that, we put the patient on prophylaxis. We give him GVHD prophylaxis and also infection prophylaxis. The drugs that were used were in this patient were cyclophosphamide, mycophenolate mofetil, and cyclosporin. And also for infection prophylaxis, we gave him levofloxacin, sulfamethoxazole, and trimethoprim, fluconazole, acyclovir. Patient did well for 19 days, but on the 19th day, he developed a rash over the arms, forearms, thighs, and erythema over palms and soles on the post-transplant 19th day. And at this point, we took a dermatology consultation, and it will be Dr. Patel, junior resident in dermatology, will describe about the skin rash post-BMT transplant.
Thank you, Dr. Abhilash. Good morning, respected faculty members, respected seniors, and my dear colleague. So the patient was referred by a clinical hematology department on day 19 post-transplant with erythematous macular rash since last 1 day associated with mild itching. Further, patient gave a history of rash starting from palms and sole with further progress to involve bilateral upper limbs, lower limbs, and trunk. There was no history of fever, malaise, headache, cough, sore throat, breathlessness, nausea, vomiting, diarrhea, and abdominal pain. On mucocutaneous examination, there was multiple well-defined erythematous macules coalescing to form patches present over arms and forearms. Similar lesions were present over lower limbs, palms, and sole, and there was no mucosal involvement. So I would like to ask the audience, what could be the differential diagnosis of a macular rash in our patient? Okay. So the probable differential diagnosis of a macular rash in our patient were engraftment syndrome, viral exanthem, drug-induced macular rash, and acute graft versus host disease. The engraftment syndrome, the rash usually appears 7 to 14 days post hematopoietic stem cell transplant, associated with fever and breathlessness, which was absent in our case. The second was the viral exanthem. Usually the viral exanthem present with prodromal symptoms and signs, and the distribution of rash is in a cephalocaudal pattern. And the third was the drug-induced macular rash, as there was a history of multiple drug pre and post-transplant, and the rash was associated with pruritus. And the fourth differential was acute graft versus host disease, as there was a history of allogenic hematopoietic stem cell transplant. Rash usually started over palms and soles, associated with pruritus, but there was no history of GI symptoms, and the serum total bilirubin level was 0.4 mg per deciliter, which was normal. So to confirm our diagnosis, further serological investigations and skin biopsy was advised. Now I would like to call Dr. Adity Mundra to discuss on biopsy.
Thank you, Dr. Meet. Very good morning to one and all. I'm Dr. Adity Mundra from the Department of Oncopathology, and I'll be discussing the histopathological aspects of this particular case. So we received a 4 mm skin punch biopsy from the skin over the left knee. Microscopic examinations revealed the epidermis and the dermis. The epidermis shows irregular thickening, which is termed as acanthotic epidermis. Within the epidermis, we saw few round to oval polyhedral cells having pink eosinophilic dense cytoplasm with a round to oval nucleus. These cells were termed as dyskeratotic keratinocytes. What do these cells signify? These cells signify abnormal maturization of keratinocytes within the epidermis. Also, the stratum basal layer of the epidermis showed vacuolar degeneration. The superficial dermis showed increased proliferation of vascular channels, as we can see over here, and these vascular spaces were surrounded by lymphocytic inflammation. Similarly, the hair follicles were also surrounded by lymphocytic inflammation. So after summarizing our clinical presentation findings, our microscopic examination findings, which were acanthotic epidermis, dyskeratotic keratinocytes, and presence of perivascular and perifollicular lymphocytic infiltrate, a final impression of acute GVHD was given. The closest differentials for this particular case were drug-induced exanthem and virus-induced exanthem. Now I request Dr. Priyanka Soni ma'am to come to the dais and further discuss the case.
Thank you, Dr. Aditya. Good morning, respected seniors, colleagues and students. So our patient turned out to be having acute GVHD, acute skin GVHD. So the graft here was a transplanted donated tissue by the healthy donor, and the host were the tissues of the patient. So GVHD means a systemic disorder where graft's immune system recognize host as foreign and attack the recipient's body cells. So it can be simply explained by a three-step model in which there is tissue damage initially, which is mediated by the disease itself, infections, medications given, and conditioning regime. In the second step, there is donor T-cell activation, which leads to cytokine secretion, and in the skin, the Langerhans cells are the antigen-presenting cells, which present antigen to these cells. And in the last step, there is target cell apoptosis, which is mediated by both innate immune system and by cellular and inflammatory mediators. There are multiple risk factors for GVHD. In our patient, we already had a haploidentical transplant, which was half matched, which was itself a risk factor, and to add on to it, we did a PBSC graft, which was again a high risk factor. The donor was older than 40 years, and we have used myeloablative conditioning, which leads to increase in the risk of GVHD. We need to classify GVHD based on the timeline and the symptoms as acute and chronic. In this case, GVHD appears on day 19. It was involving only the skin, and so we call it classic acute skin GVHD. We evaluated other organs like liver, there were no symptoms, like gut, there were no symptoms. It is very important to stage the disease because we need to decide the treatment as well as the prognosis. We stage them by MAGIC criteria. So in this case, we use rule of 9s in the skin as we use in the burns to grade the GVHD. It was stage 3 because the skin involvement was more than 50%, and we need to look at the other systems, and on the basis of that the grade was 2. So this is the pattern which we follow for management. So we had acute skin GVHD, stage 3. So we started the patient on systemic steroids. We have these second line options in case we need them and the patient does not respond to the first line. So is GVHD a good thing? Yes, GVHD is important because we need these donor T cells to mediate the graft versus leukemia effect, which is the actual purpose of doing the allogenic bone marrow transplant. So these T cells recognize the AML cells and they kill them. But on the other hand, the same cells can destroy the normal host tissues and can cause GVHD. So to further course, the patient developed this acute skin GVHD, which was stage 3 and grade 2. We started him on methylprednisolone at 2 mg per kg. Gradually, the rash decreased. We were lucky. He responded very well. And we discharged the patient on day 26 with tapering of steroids and close follow-up. So this was the discharge pic of the patient and donor. But we still have some more things to tell you. So when we discharge the patient, we do a very close follow-up twice weekly. We do organ function testing. We monitor cyclosporin levels because we need to maintain them adequately to maintain adequate immunosuppression. And another important thing is we do CMV PCR quantitative analysis again twice weekly. So on day 42, he developed a CMV reactivation, which was based on the CMV quantitative test. There were no initially symptoms, but we immediately started him on injection ganciclovir at the dose of 5 mg per kg, but soon he developed hemorrhagic cystitis and he need to be admitted. And despite 14 days of ganciclovir, his CMV titers were rising. So we moved ahead and we started him on second line anti-CMV therapy. We started him on injection cidofovir, and simultaneously we were decreasing the immunosuppression, that is the steroid which we started for GVHD to balance it. Subsequently, he developed severe pancytopenia because of the antiviral drugs, that is injection ganciclovir, and he actually had a second episode of acute skin GVHD because we have decreased the immunosuppression and which has responded to topical steroids because it was stage 2. Then we gradually tapered the immunosuppression, taking care of GVHD with close monitoring, and finally we could achieve this day plus 290, 2 days, this was a picture 2 days back, where this is the donor and patient both. Immunosuppression has been stopped completely. Currently there is no GVHD and there is no infections. But I would say that was it really worth it? So the prognosis of adverse risk AML without DNT is just less than 10%. Here in the disease assessment, so we have been doing disease assessment at various time points by doing bone marrow assessment, and the bone marrow was in complete remission. We also assessed the graft function by doing chimerism analysis, and it showed 100% donor cells. So I would say that long back the chance of cure of high risk AML would have been less than 5%. And with the current facility in our center, we are providing the state-of-art treatment that we would have received at any center in the world. And with this, we are able to increase the 10-year survival of our patients to more than 70%. DNT is although highly labor and resource intense procedure, the patient has to be maintained on 0 counts for weeks and there is 100% risk of death. But early diagnosis, close follow-up, treatment, being vigilant is key to avoid 100-day mortality. It is a very long treatment. It requires commitment from the family, patient, from the staff and from the doctors. It entails a lot of complications and enormous cost too. But I am proud to say that we are the only center in Rajasthan who is providing state-of-art DNT treatment under all government schemes. So this all treatment he has received absolutely free of cost. Thank you.